Well, good evening, everyone. My name is Bethany Yeiser. I'm with the Cures Foundation. CURE stands for Comprehensive Understanding via Research and Education into Schizophrenia. And it is my pleasure to introduce Dr. Elissar Andari tonight. She completed her PhD degree in neuroscience and physiology from the University of Claude Bernard Leon I in France, actually, and a postdoctoral fellowship at Emory in Atlanta. She is currently an assistant professor at the University of Toledo in the Department of Neuroscience and Psychiatry. So, welcome, Dr. Andari.
Thank you very much. Thank you for the invitation and thank you for being here with us. So I will go ahead and start. I actually don't see anyone, so I just see my screen. But if you, I guess you will have, if you have questions, I'm happy to answer at the end. So we'll talk today about mental health and navigating life's social challenges. And I want to start about, sociability, as this would be like the main focus of today's lecture is about social communication and social cognition. And really, if we think about it, our life is full of social interactions. As humans, we seek social interaction all the time, and most of our actions are socially oriented. So we need social contact, and I wanted to share a slide, like a more personal slide, to show you some of my kids. These are my boys, but to show you that there are, as you know, of course, there are so many different kinds of social interactions, right? And where we need to communicate. And that could be between mom and her child, like you see on the left side, me and Alexander. He's my oldest boy. You can see that during pair bond formation, right, between people who are in love. You have my mom and dad. That's in the 80s. Also between a father and child. But you can also see it, the interaction between siblings, right? Here you have two brothers, me and my sister. Even interaction between people and animals and pets. But then you can also see different kinds of interactions at work. Interaction at work with your colleagues. You can have also kids at school with their friends. So there are so many different types of interactions, and where we need to communicate, right? And where we try to communicate. But the interesting thing is that we kind of take it for granted. We think that that's an easy thing. Everyone can do that, and we do it great all the time. But that's not the case. Sometimes it's actually complicated, and most of the time, because you're dealing with different personalities every day, as you can imagine. And even within the household, sometimes you have kids with different personalities, you have partners with different personalities, and you go through the challenges, you get challenging times and sometimes happy times. So it is, I think, I really believe that it can be very complicated. And that's why, I try to study that in terms of neuroscience. And even in neuroscience, from neuroscience perspective, like social neuroscience, it's also, difficult to study because there's so many factors that can influence a social behavior. And I just want to mention that, healthy relationships are so important. We need that. That's so important for us because that can actually improve physical health. There are so many studies showing how healthy, positive relationships can be very important for our mental well being, for even longevity, less diseases, etc. But then if you take the other extreme, with toxic relationships or difficult, problems and stuff, they can actually have severe impact on mental and physical health, leading to stress, anxiety, mental disorders, like this depression, emotional exhaustion, PTSD, a lot of times trauma, right, because of that, and sometimes long-term physical illnesses and cardiovascular issues and stuff like that. So, and that's all actually, scientific evidence, based on scientific evidence. And I just want to mention, I know not so many maybe are interested in too much neuroscience, but I just want to mention that like I give it I actually give a talk and a course. I lead a course on cognitive neuroscience, and I keep saying that all our behaviors, not only vision and auditory system, right, are encoded in the brain. Like we have the visual cortex for our vision. We have the auditory cortex responsible for actually hearing. Voices or talks and stuff, but also social behavior and our actions and our emotional, state are all encoded in the brain. There are so many research now showing how there are specific areas in the brain, like for example, in the middle brain, you have the anterior cingulate cortex and you have the insula. These are so important for emotional contagion, like to feel with others, right? To feel empathy towards others, to kind of have these emotional reactions and spontaneous reactions. Then you have areas like the TPJ, like you see it here on the screen, which is temporal parietal junction. That's like more in the temporal area, and that's more involved in understanding intentions of others. Like that's cognitive empathy, right? Like a lot of times, especially with babies that don't talk, or even in everyday life, in every social interaction, you kind of need to understand what people are thinking about, and what are their thoughts, and kind of putting yourself in their shoes, like we say. And that's the area that will be activated, to actually be able to do that. And theory of mind, that's what we call theory of mind, understanding others' intentions, is essential actually for our daily life and our interactions. And so I want to kind of start with talking about autism spectrum disorder, because that's kind of what I mainly work on. And that's also an example for you of when social interactions are difficult, right? For these people, they struggle with social interactions and social reciprocity, and they can have social deficits. And then we will see that they have high comorbidity also for schizophrenia. And so, based on 2025 CDC report, actually, there is a huge increase in prevalence for children with ASD. So there's more than 1 in 31 children have ASD, and that's like around 8 years old. These are studies based on that. And we know that ASD is more common in boys than in girls. Now, that could be related to, in part, to a lack of diagnosis. There is a huge problem in actually, overseeing and not actually diagnosing early girls, because they have the masking, capacities, and sometimes it's overseen, overlooked, so we don't know that they have autism. We also believe that girls might present the diagnosis of autism differently, a little bit, with more anxiety related symptoms that might be overlooked and just unfortunately not being diagnosed until later in adulthood. So that's why maybe these numbers are shifted. And so the main characteristics, like I mentioned with ASD, they have problems with social communication, interaction, and they also present some kind of restricted and repetitive behaviors and interests. And so based on DSM, like most clinical, let's say, diagnostic criteria, they consider there are 3 levels of kind of severity. And sometimes you need a lot of support, and sometimes requiring a lot of support. Level 3, substantial support. Level 2, level 1 is usually not so much requiring support, but you still have social deficits. So social deficits are key in ASD. And the signs start early on. Babies try to avoid eye contact. They do not respond to the name by 9 months. They do not show facial expressions like happy, sadness, and anger. That kind of coincides with schizophrenia in adulthood, where people talk about blunted, not so much of facial expressions. So that's something maybe common. And they don't like to play interactive games by 12 months. They don't use so much gestures. So it's known for nonverbal cues. They have difficulties with that. And they do not point, for example. These are like early symptoms that we see in children. They don't notice when someone else is hurt, you know, and do not notice other children, join them to play. So there's really lack of interest in playing with others. Do not pretend to play, or pretend to be someone else, like a teacher or superhero, that you see a lot of kids going through that. For instance, my son Caesar is all about Batman. But there is also variability between kids. It's not necessarily that they should have autism if they don't pretend to be someone. Some kids do not like that, and others like it a lot. But if you add up all the traits together, and there are specific diagnostic criteria that clinical psychologists go through, or psychiatrists, and they will be able to diagnose ASD. Um, and here are more details about some signs that we see early on. For example, for the repetitive behaviors, but also in the language, you can see repeating words or phrases over and over, switching on the lights off, on and off. These are kind of sensory related issues that they have, and that can be rewarding to them. But a lot about routine, doing the same thing over and over, and they don't like disruption of the routines that can, be very annoying to them. So they can have obsessive interest in things. Like I said, gets upset from minor changes, and they love to follow routines. Um, of course, there's a huge heterogeneity in ASD, and that's what I actually study a lot in my lab. And I'm happy to answer more questions about that at the end, but there's a huge heterogeneity, and we're trying to look at subtypes and subgroups, because you can have not only different levels of severity, but actually different kinds of ASD, with sensory problems versus social problems versus, neuroticism associated problems. So there is a huge variability. And as I said, so ASD is associated with a huge comorbidity. There is a lot of things that are associated to ASD, and more common in ASD than in the normal population without ASD. Okay, so 70% of autism, at least they have some comorbid disorder. To the point, I mean, if you look at anxiety and depression, which are kind of neuroticism, right? It's about negative valence. It's a huge percentage, at least 45%. That's what you know in the literature, but psychiatrists would tell you that a lot of people on the spectrum, most of them, they take SSRIs, they take anxiety-related medication. And I'm actually writing an opinion soon about how I believe that anxiety, negative valence in general, and emotion dysregulation can be actually part of core deficits of ASD and not just social deficits. But yeah, you can see learning disabilities, of course, neurological, GI problems, sleep disorders, but schizophrenia too, as well, and other psychiatric disorders. But schizophrenia, for example, alone is more like 3 to 6 times more common in ASD than in controls. Also, I was looking at the psychotic symptoms. So you can have ASD with psychotic symptoms, and that's 35% of them. And if you look at the medication that are the only medication approved by the FDA for autism, they are mainly antipsychotics, and they manage irritability. So not all antipsychotics are given for autism to treat if they have schizophrenia associated. They are sometimes given for actually to help with irritability, and even without necessarily a co-diagnosis of schizophrenia. So just I'm trying as We're talking about both topics today. And, if you look at the history, they definitely, autism and schizophrenia have a strong historic connection. And actually, early on, it was autism was confused with schizophrenia. So they were not distinct disorders. At the beginning, they did not know about autism. They thought all these patients are, having schizophrenia. But then, like Eugene, for example, in 1911, he coined the term autism. He said, okay, that's for describing some patients who have these apparent withdrawal from the outside world, and that we're observing in schizophrenia patients. And then 1940, Leo Kanner, that kind of talked about autism again, but he thought that that could be an early onset because autism is in early childhood, schizophrenia in adulthood. So they thought that that could be kind of an early onset for schizophrenia. Now, that can happen, right? You can have, of course, kids that have autism and then develop schizophrenia, but that's not the case for everybody. Michael Rogers, it's only until the 1970s, if you can think about it, that autism became a disorder on its own, independent of schizophrenia. That's, so it's actually not a long time ago where when autism was considered as an autism disorder and then separated from schizophrenia. So we know today that they are both distinct, so we're not saying that they are the same. We're just looking today, we're presenting about the differences and where there's overlap and things like that. So we know that autism is diagnosed early in childhood, right? Versus schizophrenia is more diagnosed later in adolescence or early adulthood. And autism is more like known for a stable kind of trajectory and more of the improvement. So with behavioral therapies and interventions early on, a child, especially high functioning that have verbal, if they have verbal skills and cognitive skills that are intact or preserved, they can actually show some improvement in terms of social skills. And with medication for comorbidities, you can actually show improvement. With schizophrenia, or also you can show improvement with medication based on literature saying it's more persistent long-term impairment, but also with medication you can see an improvement. ASD is more characterized specifically by social communication problems. So you can't diagnose autism if they only have, for example, intellectual disabilities. That's not autism. Autism is mainly, you need to have social deficits to actually be categorized as autistic. Now, for schizophrenia, it's more defined by the psychosis terms, right? Delusional beliefs, disturbances, and disorganized thoughts. So there are some differences there. But, despite the differences, there are similar impairments if you look at the neurocognitive measures, social cognition. So that's kind of where I'm focused on because I work on social cognition. And it happened to be that they both have social disorders, and that's specifically with the negative symptoms. We'll talk about that in the next slide. They have also similar abnormalities in the functional connectivity in the brain, how the brain works, and we'll talk about that. So it's similar networks, but that doesn't mean they have the same deficits. So we'll see there are some slight differences. And they share genetic liability. They, co-occur more frequently than by chance, like we talked about, 3 to 6 times more often. As 12% of schizophrenia spectrum disorders, including different disorders, schizophrenia and ASD. So there's 12% co-occurrence. So where the overlap, and that's where the literature is talking about, and I got interested in this point specifically, is like I said, the negative symptoms that we see in schizophrenia. That's based on criteria A5, and also social communication deficits in autism. So mainly the social domain, right? The social deficits. Now, if you look at the actual criteria, there are some differences, right? Within social deficits. Social deficits is a big term, social cognition. There are so many ways where things can be difficult, right? Autism is a lot about social emotional reciprocity. You can see that in schizophrenia as well. Problem with reciprocity, to have a conversation like and ask about someone else, not only one way. So autistic will be more on the one way kind of communication. That's if they want to communicate with you. It will be more like an odd interaction. Lack of nonverbal so they avoid eye gaze, for example. They do not look into the eyes. They don't do so many gestures to kind of explain what they're talking about. They don't do pointing. They don't follow eye gaze, stuff like that. And so it's very hard for them to develop, to initiate, especially. A lot of times they have aloofness and they just want to stay in their basement. They don't want to interact with anyone. And that's one of the subtypes. And then you have others that are more active, but they have these odd kind of ways of interacting with people that makes it difficult to maintain relationships, to maintain jobs, to have adaptive skills. Versus in schizophrenia, it's more about these diminished emotional expression, right? And alogia, or like inability to express thoughts and feelings verbally, anhedonia, again, reduction in desire to engage, and asociality. So, interestingly, when there is psychosis associated to autism, apparently they show less restricted interest and repetitive behaviors, and autistic will have more kind of affective symptoms. And there are some studies, there are not so many studies comparing directly autism adults with schizophrenia. Um, I mean, comparing autistic and schizophrenic participants matched by age and other factors. But, there are a few studies and they show differences. For instance, like they have social deficits, but like autism will be more of like asking less questions their neighbor. Like that's a study on how people interact with their neighbors. And in contrast, like schizophrenia are more socially engaged, but have more of this blunted, affective kind of expression. And I really got interested in theory of mind studies. I thought that was interesting, showing how we know that in autism, they have a deficit in theory of mind. That means they have really difficulties. And it has been shown over and over for the past 30 years or 40 years. I mean, people keep publishing on this because it's nice when you find a finding and it's replicable. And I think researchers love that, and they start, doing all over this again and again. And I'm not a fan of that. I like more, I'm more on the innovation side. So I don't understand why are we keep doing these studies over and over. But apparently it's a thing, and I mean it's important to know that they definitely have difficulties understanding what someone else is thinking about, and that comes back to the social reciprocity. So if you don't understand what this person is about to speak, and like I mentioned in my first slide, social interactions can be complex, right? So you kind of want to understand what's going on, why is this person, baby crying? They don't speak. So you kind of need to figure that out. So if you have a deficit in theory of mind, you would have trouble understanding, what this baby needs, and therefore keep crying, and you get frustrated. So that can impact a lot of things, in daily life. So that can be difficult. I dealt with somebody who had deficits in theory of mind, and I remember he would keep asking me like, "Hey, please make a list of things." After like so many interactions for years, and he would keep telling me like, "Hey, can I have a list of things?" So if I'm explicit and I give him a list, for example, of grocery stuff or things, and then they can do it, but they can't like understand and intuitively what I need or what I want, and despite like learning over time, but they still would want a list. So that's interesting. But with schizophrenia, apparently the poor performance were mainly driven by an overreactive kind of theory of mind. A lot of studies are showing like faster reaction time. So they are faster. They can have a more pronounced kind of theory of mind that can lead to kind of paranoid tendencies, like thinking too much about the eyes. For example, they hear and they present the eyes, and you kind of want to understand what are the emotions associated with the eyes. And so they could like jump to unusual conclusions about someone else's intentions, but that's by over kind of thinking, over reactive theory of mind. And they can have both difficulties in understanding facial expressions and emotions. Um, and this is a study on facial emotions and like different emotions on the face, especially complex emotions. Both of them have difficulties. Now, schizophrenia, they have more difficulties if they have lower IQ or lower psychosocial functioning. That wasn't the case for autism. So somehow the cognitive aspect in schizophrenia can actually help them. So that can be a positive thing for social functioning. In terms of brain, there are also a lot of neuroimaging biomarkers, and you can see that. For example, autism is known to have an overgrowth in the brain, right? The brain is, you have an increase, for example, enlarged amygdala, which is the center for fear and emotions, when they are very little in toddlerhood. Schizophrenia is more, shrinking, like you have a reduction in cortical thickness in the middle childhood and adolescence. That could be a biomarker for developing schizophrenia. Also, there are a lot of studies on functional connectivity. So the brain, have all these kind of brain areas, and they connect, right? It's not like one area here, one area there. They all connect, and that's what we call connectivity. So it's simple as that. And we study that. And usually in autism, I see like a lot of dysfunctional connectivity between like long range, like for example, the frontal with the parietal, you have less connectivity in ASD. And apparently in schizophrenia, it can be the opposite or kind of different problem. Um, so, for example, here, again, like more precisely, the frontal areas are increased in ASD but decreased in schizophrenia. Um, while doing a theory of mind, for example, task, the ASD always show a decreased connectivity between the superior temporal sulcus. That's another area important for theory of mind. But we don't see that problem in schizophrenia, right? Because they actually have maybe a better theory of mind capacity. Um, we also see some reduction in amygdala and fusiform area when they look at faces, but that's for both schizophrenia and autism. And so that's about the connectivity in the brain. If you look at the right side, at rest, when we are at rest, this is an amazing phenomena that researchers have found, and I find it every time I do these studies. We have this connectivity at rest between the medial frontal cortex, which is in green, and the orange posterior cingulate cortex. They're always more connected between each other at rest. In autism, they actually have an underconnectivity. And they showed that autism with psychosis, right? So, kind of like as if they have schizophrenia too, they then have a mixture of, so there are mixture in findings between overreactivity or underreactivity, so connectivity, so it's not very clear. Also, I wanted to mention the saliency network. This network is so important for empathy and just to kind of realize what's going on in the social world. Let's say it this way. And there are some atypicalities in this network in ASD and schizophrenia. But again, there are subtle differences. So, for instance, you can see that in schizophrenia, you have problems between the connectivity between this network and the default network versus in autism, it's more of a problem within the saliency network. So there are some slight differences you see that you observe, but in general, what we can tell that there are problems with these kind of social cognition, default mode, saliency network kind of related in the brain for both disorders, and that could be overlapping, their social difficulties, right? The negative symptoms again, and the in schizophrenia and the social communication problems in autism. Now I want to jump into medication and treatments. And so in autism, the problem is that we don't have medication for the core deficits. What are the core deficits? Is social problems. how can you treat? It's not that it's a deficit. It's just like these are difficulties, right? Difficulties to, in empathy and in understanding intentions. These are spontaneous things. So it's really for me hard to imagine to take a drug and actually fix that. I think it's a very complex, again, social communication and social behavior and cognition. It's a very complex phenomena that we inherited, and we learn early on how to how to understand people and how to communicate. And it's hard, even in the normative range, you see all the time problems, whether it's at work, whether in our personal relationships, right? It's all about communication. So to some extent, we kind of try to learn what's the best way. Some people are more intuitive than others. And sometimes being intuitive is actually not great as well, because then you are too emotional about things. And but then not actually be intuitive, and not understanding fast what's going on can also have repercussions. So it's hard. And so, as you can imagine, that's what we say in the literature. We don't really have a medication for core symptoms, but we can treat the comorbidities, right? Like we talked about, like we have antipsychotics, etc. So I wanted to talk about oxytocin. That's what I've been working on for the past, like, I don't know, 20 years now. And I got interested during my PhD work on in this hormone. This is a neuropeptide that actually exists in the brain. That we have it in the brain. It's synthesized in the hypothalamus of our brain, and this hormone is actually released. It's a neuropeptide, but it can act as a hormone because it can be released in the blood, okay, and it can be released in the brain at the same time. And what's interesting about oxytocin, it's called the hormone or the neuropeptide of love and bonding and attachment. Interestingly, by being released, so the primary role of oxytocin was found because we have it in our body. It's very important for rapid birth. It's called rapid birth. It was known to like help contract the uterus, and so it's important for birth, also for lactation. But the early studies in sheep and mice and voles, they found that actually when oxytocin is released in the blood during delivery, during birth, it's also released in the brain for a reason, because it acts on all these brain areas that are important, has oxytocin receptors that are important for maternal attachment, for bonding. And so there are so many studies showing, like, for example, you can induce maternal behavior in virgin rats, right, after injecting oxytocin. You can block the maternal behavior by injecting oxytocin antagonists. So if you block oxytocin, you actually cannot necessarily have maternal bond formation. They will stop taking care of their offsprings. And that's in humans too. We need that, obviously, hormone to be able to form bonds and attachment with the baby. Oxytocin is also super important for pair bond formation, and you can find oxytocin receptors actually in monogamous rodent species, which is very rare, right? So we are 4% or 3% of rodents and mammals, of actually mammals that are monogamous. So and they found that those species that are very social, that have these kind of partner preference formation after mating, if they mate with their partner, they actually select this preference for the partner and they don't go with a stranger. These voles, they actually have oxytocin receptors in the areas that are the areas of reward in the brain, kind of the social brain network, right? But the very closely related species, actually, like meadow voles, they are promiscuous and they don't form any bond with their partner after they mate with them. They don't care, they go to the stranger. These voles do not have oxytocin, okay? And they have trouble. They don't have biparental care. They have trouble having offspring, so you can imagine. So it's not only about pair bond formation, but also maternal behavior. So in addition to the role of oxytocin in motherhood and in partners, between partners, and love and bonding. So in 2000, around 5 or 6, we started asking the question on whether oxytocin can actually be related to social behavior. And there are studies started to show that in the early 2005 or so, that it's also important for trust, for social, interaction, all that. So not only maternal and, sexual, but also kind of social, all right? And so I started studying, along with other researchers, oxytocin and autism to see what's going on, given that they have this trouble with connection with others. Let's see. So one of the findings I found that oxytocin have high, autism, they have higher oxytocin methylation in the saliva, and that was connected to more deficits in the brain and theory of mind areas. What does it mean? It means that the oxytocin system is not working well, right? So there's some problem. We don't know because we can't see the brain, in the brain what's happening necessarily in terms of methylation, but the gene methylation of it. So there's some methylation on the gene that actually can disrupt either the receptors or something about, release, something is happening that shows some deficits in the oxytocin system. I also found that they have lower plasma levels of oxytocin in the blood, okay? And I have done, so what we can do also with oxytocin is give it intranasally, and I actually gave it to adults with schizophrenia. So the idea was, okay, if there is a lack of oxytocin in autism, can we actually give it intranasally and try to enhance social functioning, like social trust, understanding intentions of others, or trying to maybe look into the eyes, right? And that's what I found 2000 back. I started doing this research in 2010, where I published a study showing that, yeah, if you take oxytocin, you become more aware of fair and unfair partners. And you can see here, if you look at the eye gaze picture here, you see that they start looking more into the eyes compared to placebo, where they were avoiding the eye region. They were looking all around, actually, in the hair and the sides of the face. I also continued doing more studies in the brain, and I looked into the using fMRI, and you can see that oxytocin enhances the activity in brain areas involved in social saliency, like attention to social cues. And I was able to replicate that here in the US with a dose dependent study showing that higher doses are required to actually change empathetic kind of responses in the brain, at least, okay, in response to oxytocin. So then you, like I talked about ACC, that's the ACC here in the middle, and the insula on the sides. So these are areas super important for emotional contagion, feeling with others, empathy, etc. So that's promising. Now, in schizophrenia, I did actually study back in 2021 in Atlanta, and we found like small effects, but we used the middle dose on emotional awareness and recognition of faces. So that was interesting. There are some challenges because usually we try to give oxytocin without having other treatments, and obviously most patients with schizophrenia are on antipsychotics. So, but it was well managed. And so, as of course we know, the negative symptoms, which is related to social cognition, it's much harder to treat. So there are several studies that has been done with intranasal oxytocin in schizophrenia to look into these negative, mainly symptoms, but also cognitive and positive, actually. So these are common assessments that they use for these trials. And you can see there are some improvements in the positive scale as well as improvements in the negative scales. So that was interesting. And then these are several studies showing that some improvements, especially after 8 weeks of a randomized clinical trial in schizophrenia with having medication stable, like on risperidone, for example, and oxytocin in addition. So they did sort of found some kind of improvements. There are some promising, encouraging findings, and it's well tolerated. The good thing about oxytocin, it does not have side effects, so it's very safe to take. Um, but there are some more recent studies, especially with meta-analysis, when they combine everything, they kind of show some inconsistencies and improvement, that maybe we need higher doses of oxytocin. And the problem with oxytocin, it's not like serotonin and dopamine, right? With serotonin and dopamine, you have actual drugs to give. With oxytocin, we just have the intranasal because we can't give it in the blood as it will affect, like, physiology, like uterus stuff and things, but it will not necessarily affect behavior, that we want, the social behavior. We need it to be injected, given in the brain. That's why we give it by intranasal mode. But the problem with intranasal, it has a limited bioavailability, and therefore, it disappears fast. So we need, like, future studies with kind of better drugs that can target oxytocin system endogenously, because it's a big molecule, so it does not penetrate the brain when it's given in the blood or by tablet. So that's kind of the limitation, unfortunately, and a lot of researchers are working on that, and pharmaceutical companies. And I just think I have maybe 2 minutes left, right? I can, just to let you know that, the problem with social disorders and social, difficulties, social processes, can be encountered not only, here are two examples, schizophrenia, of course, that's the main topic of, uh, of the conference, but we see these deficits in other, for example, in personality disorders. And personality disorders like borderline or narcissistic personality disorders can be very complex, and because most of them, they do not realize that they have a problem, right? With personality disorders, borderline or bipolar, etc., they don't necessarily realize that they, especially with NPD, there is nothing wrong with them. That's what, kind of the self-perception is about. And that can have very detrimental, actually, effects on partners, on family members, because this, especially the manipulation behaviors, all that can lead to, emotional, physical, and, I'm studying more the angle of domestic violence and personality disorders, and how it can, impact negatively. So we really need to increase awareness about mental problems, mental health, issues, and try to, increase diagnostic tools and biomarkers, and try to see how we can help, patients, but also families. Thank you.